So I am excited to kick us off. I'm Anissa Mitchell with PMD Alliance. Today we're going to be addressing care partners. I'm sure we have more than just care partners joining us today, but today's focus is sort of around the care partner experience of the patient journey. And this is a first in a series that we're doing with our friends with Abbott. And with us today is Dr. Faulkner. We're very excited to have him be a part of this program. He is the director of the Movement Disorder Specialist at Innova Parkinson's and Movement Disorders Program. And he's also assistant professor at Virginia Commonwealth University School of Medicine Innova campus. So he's going to be taking over here in a second and going through this patient journey. And we are going to be doing a second piece to this. It's not until December. I know that seems really far away, but actually it's only a week or two away from November. So it's going to be here before you know it. And then we're going to be addressing barriers to access in DBS. Again, engaging the care partner's perspective in this as well. So I'm going to kick this off to Dr. Falconer and say thank you for joining us.
Thank you, Anissa. Thank you, everybody. Can you hear me okay? Is my microphone working now? Good.
Perfect.
Wow, I'm looking at some awesome backdrops right now. It looks like Mr. Klickner is in the middle of the Antarctic, dodging icebergs, and Mr. Jung is on an awesome trail. It looks like. I always love the art, the backdrops you can put in, because I had one patient last time who was literally on the moon, and I thought that was fantastic. So next time I might use a on the moon backdrop. Hi, everybody. Let me bring up my slides. And while I do that, I wanted to give a quick introduction of myself. Thank you, Anissa. That was perfect. Little more info about us. So my name is Dr. Drew Falconer. I am the director of the Parkinson Center here at Innova Health in Northern Virginia, where we specialize in obviously we're a movement disorder center where we see lots and lots of folks with Parkinson's disease. I can tell you we are very busy, as most centers are. We see lots of patients. I think every week I'm clocking about maybe 100 to 120 patients with Parkinson's disease, which is a lot. But I can tell you what I see in that is a couple of things. And that's what I think we're going to really talk about today. Now, what I see in my daily practice treating patients with Parkinson's disease every day is that we see a whole host of different kinds of people, right? We see folks who are at that spectrum of coming to clinic dressed to the nines, ready for church, this smelling wonderful with their perfume wafting down the hallway as they come into the clinical room. We even had a fascinator the other day come to clinic, which was amazing. And those patients are, you go in and you say, how are you doing? And they say, I'm doing great, but they really aren't. And then at the other end of the spectrum are the folks that come into clinic with a 2-page single-spaced document that lists out all the things that are bothering them. And then everybody fills in the nice squishy middle in between. But I can tell you the common thing that we see every day in Parkinson's clinic is that every person that I see with Parkinson's is having to give up things that they don't realize they have to. Every person from that I'm doing great dressed to the nines to the patient who realizes all the problems going on. Every person has things in their lives that they're just giving to the world of age and Parkinson's, thinking that they can't do better, but they can. And that's what I want to talk about today, is I want to go through a person's journey with Parkinson's, where and how things change, the people who are involved in that bubble, to really hopefully make you realize, if you haven't already, that there is an immeasurable amount of hope out there. As of today, we have 23 medications for the treatment of Parkinson's, but only about 10% of patients with Parkinson's have touched any medicine that's been created in the last 50 years. And so if the best we could do was 50 years ago, I give up. And that's an ironic statement because we don't give up, because in reality, there are so many therapeutics we can use to try to make every day better. But it starts with, number one, realizing that better is out there and that you're all giving things up and you don't have to, and change that. Take that from I can't do dinner with my friends anymore because of Parkinson's. Change that to, I'm mad that I can't do that anymore, and I need to talk to my doctor about it. Because you need to talk to your physicians about the things that are holding you back, about the things that you wish you could do but can't because of your Parkinson's, and make the conversation be about those things, because I promise you there are things we do every day to try to make reality happen. And the other thing is, and that's what we're going to talk about a lot today, the people who surround you in your journey with Parkinson's, of course, are incredibly important. Be it a spouse, be it your kids, be it your neighbor, be it the guy who sits at the bar with you at Elks Club, whoever is going through this journey with you is part of keeping you well. And to do that, we have to realize who those people are and also have the courage to not only bring them with you to your doctor's visits. It's so important to have those people with you, but also to let them in. Let them in on the things that are holding you back. Let them in on your fears. Let them in on the things that you are giving up because of your Parkinson's. Because I can tell you this, there's nothing more powerful than having somebody on your side to support you when you start to get mad about what you're giving up and you push for better. And that's what we'll talk about today. How's that for a fine deal? And then we can finish the second half with questions. I am happy to answer anything you've got. I do this, I take care of a lot of folks with Parkinson's. I treat with a lot of therapies. Please, at the bottom of your screen, there's that little button that says chat. That's where you put all where you're from. Feel free to put in there questions you have as we go during the day. And then at the end, we'll answer as many questions as we can. Okay, let's get started. Okay, so I wanted to open with just a snapshot of the people we care for. So Parkinson's disease, and we're starting to use this vernacular as persons with Parkinson's, PWP, just to try to, in communication, it's always good to lead person first. And so we no longer say a Parkinson's disease patient. That isn't what we want to do. We want to talk about this as a person with Parkinson's disease, because you're a person first, and the Parkinson's is just part of your journey, right? But in the United States, there are actually a whole lot of folks with Parkinson's, if you didn't know that. We're treating currently about 1 million people in the US with Parkinson's. And we are diagnosing anywhere from 60 to 80,000 people every year, 60 to 80,000 people. You are not making it up. There are more people being diagnosed every day. There are more people around you with Parkinson's. And that's really because that million or so people who every day we're treating for Parkinson's, they are condensed in an age group that ranges from about 60 years old to 90. And so if you have 1 million people within a 30-year range, that's why you've seen that there are more people around. It tends to be more of a male predominant condition, but again, we treat lots of ladies with Parkinson's. And the diagnosis is more prevalent in Caucasians, though that's not really because there is a racial disparity towards Parkinson's. It's just because of the traditional barriers to care that exist in minority communities. It is at times more difficult for us to reach and diagnose non-Caucasian patients. The trajectory, though, and these words are on the screen for a reason, is what you would read as progressive and degenerative, but I want you to realize that that shouldn't be scary. The reason why that shouldn't be scary is because, yes, this progresses, yes, this gets worse, but so does age, so does life. And in reality, it takes you about 20 years to get to the point where you have movement symptoms to suggest Parkinson's disease. Yes, it's been going on for 20 years before that tremor began. And so it tends to take 20 or 30 years after diagnosis to get really rough. And on top of that, that means that we have therapeutics today that we can intervene at any stage in the progression of this thing to really help. And so that progression and degeneration is slow. It's glacially slow. It is not going to change tomorrow. It changes slowly over time. And all the change in Parkinson's disease represents, that change is just that the deficiency that is the root cause of Parkinson's gets worse. Because don't forget, at the end of the day, Parkinson's disease is not a structural problem in the brain. It is not a tumor. It is not a mass. It is not a stroke. It does not represent permanence of injury. It's simply Parkinson's at its root cause is simply a chemical problem. Your brain has stopped making as much dopamine as it needs, and when it is low, you get symptoms. And all that progression over time means is that the deficiency just gets worse. So you go from being a car that needs 15 gallons of gas to run to all of a sudden you're an 18-gallon tank and nobody tells us. And so we need to adapt how we're giving you gas back. We need to adapt our therapeutics over time to keep you your best at every moment. Because Parkinson's affects everything. It's a brain problem, but it affects every system of the body. We tend to teach patients that if you imagine a system of the body and slowing it down, that tends to represent a symptom of Parkinson's. And there's a whole list on the screen right now, but the important thing to remember, and you've probably heard this 1,000 times before, is that in that laundry list of problems that go into Parkinson's, they all boil down to simply the brain not having something it needs. And our job over time, from early in Parkinson's to the squishy middle where most people are, to the late stages, our job is to determine where your deficiency is at that moment and bring to bear our therapeutics to fix the deficiency at that time. Because remember, medications don't decline in their effect over time. You never get used to them. All that's changing over time is your Parkinson's is changing, and how you respond to medicine might be different now than it was before. And that's the beauty of today. That's the message of hope. That's the excitement. That's why we show up every day and help as many people as we can. And that message is we can treat this. This is a chemical problem, and we have 23 medicines that allow or help to give dopamine back. And you can see a whole host of these categories on the screen. Right now, we have 8 different categories of medicines that we can use. We have classic carbidopa, levodopa in many different forms, including a newer, longer-lasting version called Rytary. We have dopamine agonists. We have MAO-B inhibitors, COMT inhibitors, including a new once daily that works great. We have adenosine inhibitors like Norians. We have anticholinergics, probably don't want to use much anymore. And we have newer, better amantadine-derived drugs. 23 medicines, 13 of which are new as of the last 6 years. 13 drugs that didn't exist 8 years ago. And they are all designed to work better and to meet a specific need in the journey of a patient with Parkinson's disease. But that's what we need to talk about today. And I want you to leave today with the courage to talk to your doctor about these things, because in reality, only about 10% of patients with Parkinson's will have tried any of these medicines that are new. But you have to pair that with better living. This is a movement disorder. I am a movement specialist. We try to keep people moving. If you're not moving, the medicines we give can only do so much, right? You have to exercise, guys. Exercise causes the brain to produce extra and better dopamine, the thing that we want. And exercise keeps you moving longer, keeps you happier, sleeping better. Exercise helps everything. I can fix the dopamine problem of Parkinson's incredibly more effectively now than I could even 10 years ago. But if that's not paired with living right, good exercise, sleeping well, good stress management, happiness, then we can only get you so much better. You got to live the right life. You got to do the right things. You got to exercise, eat well, you got to sleep well. And if those things are an issue, you got to talk to your doctor about them. And remember, everybody, we have all these therapeutics, all these medications that we have to remember to take, that have to push their way through the gut to work, that have to work their way to the brain to fix the brain problem that's Parkinson's. But if the medicines are holding you back, if you're fluctuating during the day and not getting consistent good benefit, then that is when we start talking about more technological interventions like focused ultrasound or deep brain stimulation. At the end of the day, Parkinson's is a chemical problem that then turns into an electrical problem in the brain that gives you symptoms. All the medicines we use try to fix the chemical issue, but in reality, we have technology that allows us to intervene the electrical problem to try to fix the symptoms. And so that it's important to know the tools that are available and to have the courage to talk about these tools, because at the end of the day, if you are giving up things or thinking you can't do things because of your Parkinson's, that's the thing we have to put on the wall on a sticky note to fix and bring every tool we have to bear to try to get you doing that. I don't care if I feel better, if my checkbox of how I think you should be doing is good. If we don't have you back doing the things you love, then we've missed the point. And sometimes it takes you having the courage and your loved one, your partner, the person who's going through this journey with you, having the courage to ask for better to really get that train rolling down the tracks. And so who's that care team? I think this is important because a lot of times people don't realize the bubble of healthcare that surrounds patients with Parkinson's. And now this is the medical group that tends to be out there interacting with patients. Separate from this, and it could be its own slide, are the folks in rehabilitation, physical, occupational, speech therapy, who are an incredibly important integral component of keeping you well. But in the world of a neurology clinic or even a medical clinic that surrounds patients with Parkinson's, it tends to be this group. And so let's start on the lower left. Let me see if I can get the annotation tool. I usually have it. Let's see here. Oh, usually you can write on the screen. Oh, well, I can't do it on this one. That's fine. So if down in the lower left, we start with the general practitioner. Hopefully everybody here has a GP, either an internist or a family practice doctor. General practice doctors are the jack of all trade, take care of all things. They're fantastic, but they don't really know Parkinson's disease. They can identify it, usually they can see it, but knowing how to treat Parkinson's effectively is not something that's usually in the training of a general practice doctor, like an internist or a family medicine doctor. Now, that's important for everybody out there to know, because statistics show us that about 30 to 40% of patients with Parkinson's disease receive all of their health care through a general practice doctor. If you're seeing an internist or general practice doctor, it's a wonderful resource to have, but if things aren't working, it might be time to ask for a referral to a neurologist or even a specialist like me, a movement doc, if there is one available nearby. And that's where it's going to be important to talk about access. And that's where our next talk in December is going to really go into, is that access to healthcare can be a real issue. And one of the issues, especially in rural areas, is that there aren't really a lot of neurologists, let alone movement docs. And so when travel is involved, that can be a real limiting factor to getting better, right? So most people with Parkinson's receive their Parkinson's care from this doc in the upper right, a general neurologist, which are fantastic. They're wonderful doctors. I love them all to death. They know us well, at least in our area. General neurologists are the jack of all trades for neurology. They complete as a training a general neurology residency, and they treat everything. They treat headache, they treat epilepsy, they treat spinal issues, neuropathy, myasthenia gravis, MS, you name it. If you have a neurologic problem, the general neurologist tends to be the main go-to person in the switchboard to hopefully then, if things get more advanced, elevate the level of care. Now, most patients with Parkinson's receive most, if not all, of their care from a general neurologist, which is fine, but just realize that most general neurologists aren't as comfortable treating Parkinson's disease with modern therapies as you would think. And it's no fault of their own. It's not anything to scoff about. But when you have to understand and be an expert in all things, we all tend to try to rely on pathways and treatment algorithms that we're comfortable with. And for most general neurologists, that's medications that tend to be a little dated. And so what we tend to recommend is absolutely talk to your general neurologist. Absolutely bring up your concerns. Bring up the idea of more modern therapies, of smoother, longer, more predictable therapies as the goal. And if you come into resistance, if you come into maybe this, none of that works, or we don't really use any of that stuff, or I don't think there's any utility in that, then that is a great time to have the courage to get a second opinion and to be your own best advocate, to find that doctor that will talk about advancing and pushing the envelope in more modern therapies with the goal of getting you better. And for most people, I would hope that that would mean finding a movement disorder specialist, much like our center. And that's the doc with the blue box around him. An MD neurologist or a movement disorder specialist is a neurologist. We are all neurologists by training, who then did extra training to become specialists in movement disorders, the most common one we treat being Parkinson's disease. We should be there at every stage if we can. I would love to be the person who diagnoses patients with Parkinson's and treats them throughout. What more commonly happens is we tend to see people after 5, 6, 7 years of treatment by usually a general neurologist when things start to get tricky and we try to put the wheels back on track. It would be better to see earlier though. So what I tend to recommend to folks is if you can get in with an MDS, a movement disorder specialist, you need to. We are specialists. This is what we do all day, every day. Now, you'll see in the bottom here, we have PA NPs. You'll see this much more and more because we as physicians, there aren't enough of us to help. So we have a wonderful partner in nurse practitioners and PAs, physician associates in our clinics, who are extensions of us and great partners in care. We have a fantastic physician associate, a PA, who works with our center, who is a great partner to our patients, who is great with helping with access and with all the things we do as an extension of our expertise. So don't feel like if you're seeing a PA or an NP that you're getting suboptimal care, because some people have that idea. Don't think that, oh my goodness, it's not the doctor. No, PAs and NPs are fantastic. And in many ways, that's the provider who'll spend the more time with you listening and really be a deeper advocate for you to get better. So don't be afraid of PAs or NPs. They're fantastic. Most people see general neurologists. Always ask for an MDS, a movement specialist, even if you see us once or twice a year, just to make sure that we keep you on the edge of things. And then we have two more roles. We have the neurosurgeon, who once we go down that pathway of deep brain stimulation or even focused ultrasound, the neurosurgeon is the very highly trained mechanic who puts the device into the brain and then sends the patient back to us for managing whatever device is present. And the medical rep is usually, in the world of DBS, deep brain stimulation, is the representative of the DBS company, be it Abbott, Boston Scientific, or Medtronic. And they actually are the ones who help you through the journey with the device and also will help manage the device after the implant is done. So that tends to be the medical team that surrounds patients. So who are the non-medical team? And I think this is as important of a group as the other, because this is the group that surrounds us socially. This is the group that surrounds us emotionally. And this is the group that is there for the journey that is Parkinson's to help us in between clinical visits. Because remember, guys, as of today, if you're treated in a modern fashion, the life expectancy of someone with Parkinson's is the exact same with or without Parkinson's disease. So I tell every patient that when we diagnose them, I say, you're going to be okay, because you are. Your life is going to be different because you have this thing, but you have a long journey ahead of you that we need to take every opportunity to bring joy back into what you do, and we can. And an incredibly important part of that are the people you see on the screen. Now, the top one that the box is squared off is, of course, the care partner. I've been married now for a very long time. I'm much older than I look, I promise. And I know my wife is my partner, my companion. She is everything, and she is the one who will keep me running forever. The care partner is so important, okay? Now, for most people, this is a spouse. For many people, this is actually children. I can't tell you how wonderful it is to see patients come to clinic and have their daughters or their sons with them, or even in some cases, their grandchildren. That family member that cares, that is there during the journey, is so incredibly important to be present and to especially come to clinic with you. Please bring them to clinic with you. The person who lives with you, who's in your bubble, gives collateral information that helps us make better clinical decisions. They're amazing, right? We love them all. They're at the top of the list, but realize that that the care partner doesn't have to be a spouse or a family member. I can't tell you how many patients we see where it's the neighbor next door that comes to every clinical visit, cares just as much as the family member would. Or I had a guy yesterday, I mentioned Elks Club. This is his buddy that he goes to Elks Club and sits at the bar with. That's who brings him to his clinical visits. Got a sweet lady yesterday who it's her pew mate. It's her pew mate at church will come and pick her up and bring her to her doctor's appointments. Whoever it is in your lives that is there for you every day, that's the person that should come to your clinics with you. And you should definitely get them something nice for the upcoming holidays. Okay, the other people in your bubble are to the right, a very important one, and that's other people living every day with Parkinson's. For those that have, and you're here with us here, so that means you have some engagement with the Parkinson's community, but this is an incredibly powerful community of patients. So I would encourage everyone here to take full advantage of all those people around you with Parkinson's living every day. Because not only can you find tricks of the trade, not only can you find quick ways to fix problems that they're living every day too, but it's a great base of support of people who understand what you're going through every day. And these are patients with Parkinson's. There's a great group of patients with DBS with Parkinson's that even if you're considering it, are a wonderful resource to tap into. We have clinical mentors, people around you that all of these Parkinson's associations tend to aggregate. So keep involved, keep engaged, it helps. And with that, the Parkinson's groups down in the lower left. This is a great example of it, but there are many, many organizations that are being advocates for you and are putting together the resources and the programming to make sure as a community we are supporting as many people as we can. Keep involved, keep out there, find the things that you enjoy and do it. But be careful, and that's the final box. The internet is a scary place. The internet is filled with untruths. The internet still tells you that Bigfoot's alive and the moon landing was a lie. The internet will tell you what you want to hear. It's really important that if you research online resources, that you stick with the reputable organizations, some of them are listed on the screen, but continue to be engaged with educational programs like this to keep on the edge of things. Because it's really important to be a well-informed person with Parkinson's. It's really important to be a well-informed person caring for someone with Parkinson's. Because every year we get better, newer things, and every year we figure out how to do our job better. And the way you can access that is by keeping informed. And also remember, the internet is filled with the worst case scenarios. It's the best restaurant in town. They will still have a terrible review from the one person who had a bad experience, but I would still eat there, right? So take the bad stuff with a grain of salt because you don't know someone else's life or their experience, and use the internet as a way to connect and a way to educate yourself on Parkinson's. And all that comes together to be the bubble surrounding you. Because in reality, it takes people years usually to reach a diagnosis of Parkinson's. Don't know if you realize this, and I mentioned it earlier, but by the time you have motor symptoms appearing, you have tremor that starts, walking changes, that deficiency of dopamine that is Parkinson's had started 10 or 20 years beforehand. Because classically what happens is we meet someone in clinic, we see the symptoms, well, that's pretty consistent with Parkinson's disease. Usually predating diagnosis, the patient will have lost their sense of smell or have a reduced sense of smell. They're usually constipated, having problems going to the bathroom, and they normally have sleep issues and talk in their sleep. And those non-motor symptoms predate diagnosis and tend to represent that tank of dopamine slowly reducing. And by the time that dopamine is down about 60%, that's when we see those motor symptoms. But most people come to clinic worried about Parkinson's because they end up realizing things are changing. They Google tremor, and most people come up with that concern for a self-diagnosis on their own. But guess who's the most common person to bring up that they were worried about Parkinson's in clinic? It's usually not the patient. It's usually that care partner. And so that's a moment to recognize that it's the people around us, the care partners, the people who are on this journey of life with us, that know us better than we know ourselves and see things starting to change sooner. So if you have someone out there who's a friend, who has a spouse who they're worried about this, encourage them to see a doctor about it, because usually the care partner is spot on. But then after that concern, after someone finally finds a diagnosis, they usually get sent to a general practice doc. Usually they go see their internist and they're like, I'm worried about these things. And that internist will either say, I'm worried it's Parkinson's and we're going to treat it. Or they say, it might be Parkinson's, I'm going to refer you to a neurologist. And that professional diagnosis, that labeling of Parkinson's disease is incredibly important to make sure the shoe fits. I will tell you, just being honest, that we see an incredible amount of misdiagnoses through our clinic. At one point, we were tracking it, and we were tracking about 25% of our new patients were misdiagnosed in some way. It's just important to remember that a diagnosis is a working title. It is not in stone. It doesn't have to be there forever. And it's what a doctor thinks at that moment. If you have Parkinson's disease, one would expect the medication to work to help. If you take the medication and you don't feel like it helps, then you should take a step back and question whether you actually have Parkinson's. Because as of today, we have two very good tests that we can do that can tell us, that can give us objective data as to whether you have Parkinson's disease. We have a brain scan that we can do called a DAT scan that takes a picture of the dopamine system of the brain and tells us in color if it is low. And we also have a skin biopsy test called synuclein that we can use that will tell us if the abnormal protein is present. So if at all if at all the shoe doesn't seem to fit, don't just sit on it, but have the courage to ask your doctor, are you sure? Because I don't feel like the medicine is helping. And then offer the idea of a DAT scan or the skin test. I can't tell you how helpful that is to not only take the uncertainty out of the room, but to really make sure that we're treating what we think you got. And the care partner is important through all of this. And that's again, I feel like this talk, we want to celebrate the people around us. But that as a care partner, once that diagnosis happens, you really transition from being an informed observer, that partner in life, that partner in crime, you shift from that to be an active care partner. And that change is hard. That change is harder for some than others, but it really takes you from being a supportive partner to being an active person in every day to make sure the medicines are correct, to keep track and to report back on changes you see. And it's important that that person, of course, provides physical and emotional support and deals with their own physical and emotional needs too. This is a diagnosis. It goes through the same grief process as anything else. I don't remember the stages of grief, but I think there are maybe 5 of them. It was something, there's anger, and then it gets to acceptance slowly, right? Well, I don't remember. Whatever those stages are, I see people every day, care partners and patients go through that as they're digesting a diagnosis. It's important to be honest about that, because if you're newly diagnosed, you might be in one of those stages before acceptance, and that's normal. It's okay. But if you have questions or concerns, no matter where you are in that acceptance journey, that's when you have to reach out to your doctor. And reach out to support organizations, reach out to new onset Parkinson's groups, reach out to people you know in the Parkinson's community. It's about having support as you come to terms with that diagnosis, and then take that energy and put it into advocacy to push for the best. I can't tell you how many people I see who come in, they're clinically symptomatic, and their doctor told them that this was as good as it's going to get. And I look at them and I say, you're 50. You have to be able to do better than this. Let's push for it. And usually it doesn't take me doing it. Usually it takes the patient going to their doctor and say, I'm not good. We need to push for better. And that's where that anger can be put to work to try to help every day for Parkinson's. But so how can you help? So as a care partner with Parkinson's, the things that we see that are a very effective thing that really help the everyday is, of course, being a good listening ear and supporting your partner during their journey with this. And patience, of course. This is a journey. It is a long journey, but we're in it together, and patience helps. Then, of course, being that source of strength and hope. It's important to try to take that deep breath, look to the positive, look to actionable things you can do to help every day, and stay educated. Educate yourself, educate your partner, really start to assume that role of an active care partner to help maintain and help come up with a plan on what to do. And it's important that journey also goes through a movement disorder specialist if you can, because we help with that journey. But the care partner can be an incredibly helpful person too when preparing for a clinical visit. I find it incredibly helpful if the care partner comes to clinic and comes with a list of questions written out that we can address during the visit. Also, please bring a copy of the medicine list. And if anybody else in the family has questions or concerns, just write it down on a sheet of paper and we can use that as our guide. It is such a helpful starting point for us to talk during our clinical visits. And that's the journey. So if you haven't figured it out by now, the journey of someone with Parkinson's is a cycle of prescription, recommendations, adjustments, and changes to therapy. Where your partner is today in terms of their functioning, in terms of how they're doing with their Parkinson's, is not where they're going to be in 6 months. It's not where they're going to be in 8 months, but it will not change quickly. Parkinson's changes at a glacial pace, but it does change. Where you are in 3 months might be different than where you are today. And it's important to use that clinical visit in the future, or that one that you have coming up, to take the conversation from sticking with clinicals to talk about how you're doing in the things that matter to you. And here's what I recommend. So when you go see your doctor next, and the doctor says, "How are you doing?" Please resist the urge to say, "I'm doing fine." We don't want you to be the good patient. If you're good, that's great, but we don't want you showing off. What I want you to do is to tell that doctor the things that you wish you could do or that you can't do that are holding you back because of your Parkinson's. Because the moment you say, "I'm doing fine," the doc, no matter how well-being they are, is going to take a step back and say, "Oh, this is going to be a quick one," go through their mental checklist and say, "Come see me in 6 months." That doesn't work. It's important that you and your care partner who's there with you come up with the things that are holding you back, the things that you gave up on, that you said, "I can't do anymore." Put them on a list. And when the doc says, "How are you doing?" say, "I'm doing fine, but here are the things that are bugging me." And then all of a sudden, you'll talk about that list that matters to you. And it's important that you come up with a plan on how to use our therapeutics better to fix that list that you have. And that involves having the courage to do that. And it involves having the courage to push a little harder to try new things if what you're doing isn't working. But Parkinson's changes, it advances. We're dealing with a condition that'll be with you from age 60 or 65, average age of onset, to the end. So Parkinson's changes just like age. If you haven't been told yet, things are different in your 80s than they are in your 70s, and different in your 70s than they are in your 60s. So as Parkinson's changes, as age changes, as you get older and things start to change, it's important for you, as well as the care partner, whoever it is in your life, the person with Parkinson's and the person walking the walk with the person with Parkinson's. It's important that the needs and the support will grow, but it's important that we use that as a constant source of support, of encouragement, but also helping to manage all the complexity of this. It's very important that you see your doctor on a routine schedule. It's very important that the medicines are taken at the appropriate times and not missed or doubled up on. I would rather folks miss a dose of medicine than take too much, right? Or take it too close. So it's important for the partner, for the care partner, to make sure that the medications are in a good place in a very supportive and loving way, of course. And then also just keeping active. You guys got to get out there. You got to figure out what makes you happy, and you got to do it. And if you can't, that's what you need to talk to your doctor about. Because life's all about getting out there and finding the joy in every day. And if you can't do it, that's where we have to come up with a plan to allow you to do it. Because the needs, the challenge of Parkinson's, it's no secret, gets harder as we go. But finding support through our partners by pushing for better is how we keep better longer. And remember too, and that's the blue at the bottom of the screen, the best care partners actually take care of themselves too. It's really important. If you are that person on the journey with someone with Parkinson's, it's important that you find and maintain the things that you love, and that you do things every day to support your own physical and mental well-being. The best care partner is the one who takes care of themselves too. And it's so hard to do that because sometimes it feels selfish to take time out of the day or to walk away and take care of your own needs. Well, I'm here to tell you that it's not, that there is nothing selfish in taking care of you, and that the best care partner, the best person in the life of someone living with Parkinson's, is somebody who can maintain their own emotional, social supports as well. You got to do it. If you don't do it, call me up. I'll talk you into it. I promise. And guess what? If what you are doing is not working, if you are taking medicine and it's fluctuating, if you are having inconsistent response in the consistency of your day, the predictability of your medicine is the thing that's keeping you from doing things, don't forget about deep brain stimulation. We do DBS all the time because it is life-changing in the world of Parkinson's. We've been implanting DBS for Parkinson's since 2002. 20 years, this has been a standard of care in what we do. And the idea behind DBS is, again, Parkinson's is a chemical issue that turns into an electrical problem that gives you symptoms. Well, the limits of the chemical issue is that we have to take pills to push into the brain to fix it. while DBS goes directly to the source of the problem, the electrical issue, to deliver therapy and turn it off. It's darn near magical. That's why we love it so much. It allows us to reduce medicine by 60 or 80% and rely on a device that's working all the time to fix the symptoms in Parkinson's. And so if you feel like things are getting rough, if you're fluctuating, don't be afraid to have the courage to bring up DBS with your doctors too. And remember, once you get DBS, once you go down that pathway, there's a whole team of people surrounding you that are there to help. Not just the very well-educated reps from the company, but the neurology team, the movement disorder team, the surgical team is there to make sure that the big one-time step of surgery is good. And then forever after that, we have the ability to use DBS as a tool to make things better every day. And the beautiful part about DBS, the reason why we love it, is that it's adjustable, it's programmable. So as Parkinson's changes over time, we simply change how the DBS is running to meet your need then. And it works, that's why we love it. But then the important thing at the bottom is advocacy. I would challenge everyone out there that when you find that sweet spot, when you find that path and you are better, we see it every day. And if DBS is part of that, please do it for me. Take a moment, step back and be an advocate for your peers. Be an advocate for yourself, be an advocate, of course, for your loved ones. But if you find that path, go to support group meetings and tell people about it. Because I can't tell you how many people are out there that haven't heard the message that there's hope. And if you have the ability to deliver that message and show people that better is possible, you will change lives. And that's the beautiful part, that altruistic part of giving back. So the key takeaways from today, and I hope you got this from our talk, is that Parkinson's is not a lonely trip. You are not alone. There is a bubble of people surrounding a person living with Parkinson's that has a significant impact at every stage in the journey. And there's no one more important than the care partner who is there at their side, being the emotional, physical, and medical support that patients need. And so stay positive, stay engaged, seek out the support when you need it, remain educated, and take care of yourself too. And it's really important, team, if you haven't gotten it by now, that a movement disorder specialist be part of your team. Because we have this giant pathway of most people with Parkinson's, from awareness to diagnosis to treatment to DBS afterwards. It is a complex journey that takes decades, but you need to have the courage to step up and to ask for better if you're giving things up because of Parkinson's. Because I'll say it one more time, there's an incredible amount of hope out there because of the therapeutics we have, the tools we have to help meaningfully do so. But you, as the care partner and the patient with Parkinson's, you have to have the courage to ask about those things, and also the courage to show up to clinic and talk to your doctor about the things that are holding you back. That's what I got for you. My name is Dr. Drew Falconer of the Inova Parkinson Center here in Northern Virginia, where we try to change lives every day. Anissa, that's what I got for you. Should we jump into some questions? How do we do, everybody?
Yes. We have a lot of questions, and there's a lot of them popping in right now. I can't even hardly keep up with them. So there you go.
Rapid fire.
Yes, absolutely. So I'm going to go back because there was several comments made from some of our care partners in the audience talking about exhaustion.
Yeah.
You know, one person wrote, how are we supposed to have the strength, the knowledge, and the resources to sustain our loved ones and our families? There's societal expectations that can be very difficult to maintain. As a care partner, I'm not ashamed to feel and express that it doesn't help us to have an idealized image of care partners.
Right.
We're just human beings. And others are saying, I'm exhausted. So can we talk just a little bit, because you mentioned the importance of taking care of themselves as a care partner. Yeah. And sometimes that is a challenge because, you know, there's role restriction, like you don't have somebody coming in to relieve, you know, monetary restriction. There's so many things. When you're working with care partners and they come in, how do you coach them on trying to find that balance, and that they don't have to be perfect all the time, in their role. They just, they just have to do the best they can. So can we spend just a minute on that? Because this is such a hard topic to address, because there's not a algorithm, like you were saying earlier, there's not an algorithm for that.
Yeah, it's, you have to realize that no one's perfect and that everybody is doing the best they can. And that's something I tell patients every day. And I can tell you, there are a lot of things in our clinic that bring people to tears. One of the biggest is when you look somebody square in the eye and you say, you are doing a good job. So for all the care partners on here, wherever you are doing a great job. You're doing an amazing job. You are doing a fantastic job. But you got to be able, and you got to be comfortable asking for help. And that's one of the biggest hurdles that I think people fall into, is thinking, just like you said, societally, whatever, culturally, whatever you want to call it, I have to do everything, right? You don't. Allow me to be the one that made that decision for you. You don't have to be perfect. You don't have to do everything. Just be comfortable asking for help. And if that means trying to find a way to move to assisted living, God bless it, they help. If that means really having a direct conversation with your children or your family to ask for help, or if that means reaching out to your local support organizations to find means in your community that can help, you have to do it. And that's not a selfish thing. I mean it. You are doing a great job, all of you. But we need to make sure that 24/7 is not on your plate, because then you can't take care of yourself. I can tell you in Northern Virginia, there are great community resources, even through the counties, through local support organizations. We have a number of different, I mean, it's a terrible term, but we call them adult daycares, right? Those kind of places where people can go in a safe environment to watch TV, to play cards, to do everything they want while the spouse gets a little bit of a reprieve. It's not selfish, I promise. It's important. So I think the important things are to realize you're doing great, and then to have the courage to ask for help and find those organizations locally that can help. Is that a fair answer?
Yes, and you mentioned earlier the stages of grieving, and there is grief in watching. And this was what someone had written. There's grief in having your spouse turn into a patient that you watch over, not the relationship you used to have. And that is so true. We talk about ambiguous loss, because that person is still with us, but there's pieces of them that's changed. There's different dynamics in the relationship. That's a change. That's a loss. And so it is important for care partners to acknowledge that. And I love, there was someone that, I think it was Anna, mentioned that it's good, like she shares that. I think it's important to find somebody like a support group of other care partners, people that you connect with, a counselor, a social worker, that's someone that you can talk through and process your grief, because it's important. Part of this journey as a care partner, and trying to help your loved one and be available to them. And there was some questions around helping people that have loved ones that are apathetic or depressed, that are not wanting to do things. So there's actually that, like, it's okay. That's a part of the disease too, right? So it's important to also address that. And you mentioned, the quality of life or value-based care. That's a part of that. So can you spend a minute about the importance of addressing not just motor symptoms? That's important. We have lots of medications available. We have DBS for symptoms for certain people, but there's also that non-motor symptom aspect that's very important, that impacts the person with the disease as well as the care partners.
Yeah, and one of the big ones is apathy. One of the hallmarks non-motor symptoms of Parkinson's is this outward projection of disinterest. And it's not that they're not interested, it's just that people with Parkinson's tend to just kind of take a step back from the room. They tend to not be as engaged in things, and not the usual or how they used to be. And that's a really hard thing for people to accept, because a lot of times you take this vivacious person who's always been the center of attention, they turn 65, they get Parkinson's, and then they kind of slowly back away from the conversation. But the important thing to remember is that they're not doing it on purpose. And I know it sounds cheap, but it's true. Don't blame the patient, blame the disease. It's really not them. It's their Parkinson's disease that's made things change. And I tell people all the time, it's not, they're there. Keep doing the things to engage them and push for better therapies. But if it really starts to tick you off, don't get mad at them, get mad at Parkinson's. And use that anger to try to push for better in therapeutics, in engagement, in all the resources, because we actually can help in a lot of ways. And mental health is an incredibly important part of that equation, because you as the care partner, the patient with Parkinson's, this is, like you said, this is a huge change. It's a change in the future. It's a change in things you've been talking about for 30 years. It's a change in what to expect, what every day is like. It's hard. In America, we tend to kind of push away from psychiatry and managing depression, anxiety, especially with psychology and psychiatry. Now's the time to accept that that's a mistake, because depression, anxiety is an integral part of that change in life. And it's present both in patients as well as their care partners. We can treat that. We can talk through that. We can use mental health services to help with outlook, with engagement, with depression, but we don't talk about it. So add that to your advocacy, add that to your self-courage, to have the courage to talk about your mood. These are actually things we can do to help.
And to kind of support what you just said, there was a comment earlier, I'm trying to find it in this, but it was around their loved one, when they try to be a source of hope and encouragement to them, their loved one, their spouse with Parkinson's gets irritated with them. And that, I think it goes along with, that's probably related to some of the symptoms, the apathy or whatever, just to keep on encouraging them. Even though it can be wearisome for the care partner to continue to do that. But I'm curious, when you're working with care partners and they come in with their loved ones, can you talk just for a second about how important that role is? Because they're seeing a different angle of their loved one. They're seeing them every single day. So they see the good, the bad, the fluctuations. That's why it's so important for care partners to be a part of that conversation, be a part of that team, to have these opportunities to share what they're seeing at home. Because I don't know if you've experienced this, but I'm going to make an assumption that a lot of people come in and they bring in all of their energy and they kind of show off for the doctor, while the care partner is like, who is this person? Because this is not what I see at home. And so you, as a treating physician, may not see the real story of what's going on. So that's where the care partner is so invaluable to share that.
Huge. Absolutely huge. And it's because I can't tell you how many times I've seen patients for a year, and it's the patient by himself. Usually, no offense, it's usually the stoic 80-year-old guy. And we sit through clinic and we talk about everything's fine, right? Little things here or there, prostate issues, so what? Go live life. We talk about cars, we talk about movies, we talk about TV, and everything's good. And then usually after about a year, it's usually the daughter that then shows up and lays into us. And it's like, what have you been doing? He's been terrible for a year, right? We see that all the time, which is why I stress every talk I give that whoever is in your bubble, be it your daughter, your spouse, your friend, get them to come with you to your visit, because we get as much, if not better, info out of that care partner than the patient themselves. And they see it every day. Now, the counter to that, and this is a message to all the care partners on this call, is that it's that whole haircut analogy, right? If you're with somebody every day, it's hard to know they need a haircut. It's that, it's when my mother comes to visit and she looks at me and goes, you haven't had a haircut in a long time. And you look and go, oh yeah, maybe I do. Sometimes being in it all the time makes it hard to see change, good, bad, or otherwise. So that's another role for taking time for you, for stepping away, and also making sure that over time, don't keep a journal, but try to keep a log of how things are going. Because whenever you go to clinic, one of the things every doc is going to ask you is, what's different? How are you compared to 3 to 4 months ago? And I don't know about you, but I can't remember what I had for lunch today, let alone what I was like 3 to 4 months ago. So maybe at every doctor's visit, to get a notebook and write down the main things that are bugging you, and write down the things that are holding you back, and use that as kind of a touch point at every visit to be able to accurately answer that question about what's changed.
I want to switch gears just a little bit. We had a question, and this is kind of a specific, but I think it might be applicable to other people. A gentleman asking about his wife. So this person was diagnosed 5 years ago, and what they're struggling with is their voice. They've lost their voice. They've done speech therapy. They were told that Parkinson's is robbing the voice and there's nothing more they can do about it, even though they practice their voice therapy and things like that. And it's their most challenging symptom. And so if it's challenging for the person with the actual issue, it's extremely challenging for the care partner. What do we do in these kind of situations?
Voice is hard because the voice is a muscle and you have to think about it as a muscle. There are a lot of treatments to Parkinson's that make voice better, but in some people, the voice remains quiet. Speech therapy is usually pretty magical for voice. Specifically, there are a number of different voice-specific Parkinson's therapies. One of the biggest is loud therapy that you can usually find near you. It's LSVT loud therapy. It's like boot camp for the vocal cords. It works beautifully. So I find people can find that path forward by thinking about the voice as a muscle, just like everything else. And if a muscle is weaker, voice is quiet, then the best way to fix that is to build strength, which we do through therapy.
And there was also a question about pain. And that's a huge quality of life.
Sure. Yeah, pain's hard. I mean, it's terrible, but it's a hard thing. It's just like we have a lot of people who just feel tired, right? I'm just tired all the time. Or some people who say, I'm just foggy all the time, or I just feel off. Well, unless it's my joint hurts in my elbow because I hurt it, then pain fits in that category of being very general insofar as it can be caused by anything. So anytime we get hit with a symptom that could be due to everything, it's important to first determine if it's related to Parkinson's or not. And if it's related to Parkinson's, then we can create an identifiable source of the pain that we can try to treat. But if it's not due to Parkinson's, then it's important to not leave it as a wishy-washy, I just hurt, but instead really identify what's causing the pain so we can make sure the right doctor and the right treatment is addressing it. Can't tell you how many people I see who come in and say, I hurt all over the place. And then you really dive into it and you go, no, you've got spinal arthritis and no one's ever looked because they all blamed it on Parkinson's disease. Don't forget, Parkinson's causes everything, but it also might not cause everything. And playing that game of what if it's not Parkinson's actually allows us to attribute other things to the problem and gives us different paths to try to make it better.
Awesome. Well, I think we're pretty much out of time, but I have one statement that just came in that I think is a great one, and like your take on it. This person saying, wouldn't it be great if at the appointment, the PD patient and the care partner were asked what problems each would like to see changed or improved?
Well, I'll flip it around and realize that, and make you realize that there, and I know doctors, I am a doctor, I teach doctors multiple times every day of the week, and you all see doctors. I don't think it's a surprise for me to tell you that there are very few doctors out there that would ask the patient what symptoms they would like to improve, right? Most doctors say, how are you doing? Yep. How's your walking? Yep. Sleeping okay? Okay. See you in 6 months. So if you want doctors to ask care partners what they want to help, you need to be the advocate to bring that up. And that's where it comes into having that courage to really stand up and be vocal. And, you don't have to be a jerk about it, but just ask, these are the things that I see as a problem. These are the things that I would like to make better. And then this is my partner. This is what he's bothered by, or she. This is what they want to make better. What's the plan? What are we going to do today that can address the things that I see and the things that they see? And how are we going to try to make these things better? It has to start with you, because we do everything we can to educate doctors better, but doctors are doctors. We're clinical. You need to make the conversation about you and your loved one. And that's where it starts.
Awesome. Well, I want to thank you so much for your time today in this presentation. It was fantastic. It was great to engage all of these questions at the end. So if we didn't answer your question or ask it, we apologize. There's always more questions than we have time for. but you did a great job answering some of these challenging questions. So thank you so much, Dr. Falconer. Appreciate you. And I want to thank Abbott for making this possible. And I want to encourage everybody, if you don't already have your camera on, to turn it on so we can give Dr. Falconer the thanks and wave of gratitude. So thank you so much. And you all have a great rest of your day.